And this is open for discussion, and I'd like to introduce our panels, Dr. Chan Jung Kim and online, and Kim Tae-hun and Oh Kyu-chol, Im Sung-min, Jung Young-hun, Hwang Byung-hee. Please feel free to raise questions.
Hello. 안녕하세요. Hello.
네, 잘 들립니다.
Yeah. Thank you for inviting me this prestigious conference. I'm having a wonderful time in New York, Mount Sinai, and I'm personally thank you, Dr. Maron and Dr. Dangus. And my question, as Dr. Maron wonderfully summarized in her lecture, there was several very good strategy has been published in previous decades. But there was roughly two strategies. One is as Dr. Maran preferred, P2Y12 monotherapy after PCI, after initial phase. But there was another trials as we have like the thalassemia and the post-therapy issues. There's a aspirin plus less potent antiplaque therapy. So my question may go to Dr. Maran and also Dr. Han. Which one would be preferable in after initial phase of acute syndrome after PCI? Can I have it? Yeah.
I can take that. Just after initial PCI, I feel very compelled to give patients potent P2Y12 inhibition because of the variability that we see with clopidogrel. And so in my mind, a P2Y12 monotherapy with a shorter duration of DAPT, especially if there's a high bleeding risk, is more preferable than going to clopidogrel or even clopidogrel monotherapy, which we saw not work very well in stop DAPT ACS. So I'm more reluctant in ACS patients to de-escalate to clopidogrel, especially if it's monotherapy.
Can I have your
I agree with Dr. Moran. As I mentioned in my presentation, my default strategy for ACS patients is aspirin plus P2Y12 inhibitor, preferably Prasugrel in my case, for 12 months. If patients have a high bleeding risk or have minor bleeding or complaints with bruisability, I reduce the dose of Prasugrel or Prasugrel to clopidogrel. But the proportion of patients with HBR is not so high in Korean patients. In our SMART trial, the proportion of patients with a precise DAPT score of 25 or higher was only 25%. And in the STOP DAPT2 trial, subgroup analysis, the proportion of patients with HBR-ARC was only 1/3. So in most patients, we can continue the adaptive aspirin plus potent P2Y12 inhibitors after ACS.
We have data regarding the prevalence of HBR in our PCI cohort. That is about 1/3. 2/3 are low BR, 1/3 is HBR, based on the host BR RCT enrollment status. But interest findings in our interim analysis, the incidence of event of HBR is about 3-fold higher than low BR. That's actually HBR issue is very important. In this context, at least in South Korea, we prefer more lenient antiplatelet regimen than a stronger agent such as TICA.
Yeah, as an inventor of the concept of stage and paradox, I must be sorry for the doctors because I can make some hurdles to publish the excellent data from Korean society. Actually, I suggested this concept almost 10 years ago. My feeling is like this: the standard dose of Prasugrel, Tacrolimus would be too strong for East Asian, including Korean patient. Unfortunately, now the concept of de-escalation and the abbreviation of that strategy is so widely accepted in Korean society and even in global society together. So, in this point, I would like to ask the question to Meran and Dr. Han. The de-escalation strategy is widely used, tested in multiple trials. How do you think about that? The HBL patient is a good candidate for the de-escalation, or other patients no applicable for the de-escalation strategy? How do you think about?
I think in all things are possible for all patients, depending on the timing and when we're doing these things. In my mind, if a patient is a high bleeding risk and we're very concerned about the potent agents, we can de-escalate. But there has to be, if there's a complex PCI, I feel uncomfortable to go with a clopidogrel monotherapy. And I would want to make sure that they're at least responsive to clopidogrel, especially if there's a stent in the left main or bifurcation stenting or something like that. So I'm more reluctant and more nervous about de-escalating without testing. So I think, there is a place for everything. You can go with potent agents alone without aspirin for some time in that early period, and then go down to de-escalate to clopidogrel, and then test them to make sure that they're actually responding.
Can I ask a question to the Dr. Dangas? You showed the data of ARTE or popular TAVI RCT. I think both RCTs results is not so important for us because ARTE just 200 patients for 3-month follow-up. Just message is DAPT increased bleeding, then aspirin, just immediate after TAVI procedure. Popular TAVI is also small sample size, just 1 year follow-up. The difference between DAPT and aspirin monotherapy is just difference of bleeding immediate after TAVI. But when you consider valve durability, stronger agent would be better than weaker agent based on Atlantis CT, 3D CT data or Galileo trial, suggesting warfarin is better than apixaban. Apixaban is better than DAPT. In Galileo, rivaroxaban is better than antiplatelet agent. Thus, with this context, I don't agree aspirin monotherapy is preferable to DAPT after TAVI procedure, considering longevity or MACE beyond 1 year or 5 years. I think DAPT may be better than aspirin monotherapy. How do you feel such kind of proposition?
Well, I have to agree with you that the studies, there may be several, but each one of them, it's rather a pilot study. About 100 patients per group in the ARTE, just a few hundred in the popular TAVI, definitely not a lot. In order to be powered properly to answer this question is you need thousands of patients. So we're not anywhere near that. And I also agree with you that the difference they show is mostly related to the loading dose of clopidogrel. So that is very procedural, where they don't address at all if there could be a benefit or there could be a harm if you start the more potent therapy upon discharge. That's really the question we really want to answer these days. And I agree that this needs to be studied in the longer term because a lot of the benefits would be in the durability aspect, perhaps in follow-up echoes and things like that further down the line. But I think that the tolerability of these medications has been pretty good for the several months after the procedure. So I do think that perhaps even a monotherapy trial would be good in a larger scale. And clearly a large-scale trial is lacking from this field, particularly since TAVR has become so popular and that there are many procedures now involved with this type of device. There are plenty of devices, quite frankly, and the devices need to be used appropriately with a correct and well-tested medical therapy. And I think we're lacking. I agree with you. That we're not anywhere near. We can show slides of trials, but each and every trial, when you look at it, it's just a pilot, nothing more than that.
But guidelines support aspirin monotherapy after TAVI. So I think it is too far based on really weak evidence.
The evidence is weak. I agree with you, but there is a little bit of a momentum, and the momentum towards simplicity. And in that momentum, it's a best guess, I would say, and not really evidence, clear evidence. It's best guess. And a conundrum of small studies ended up. That's why in my concluding slide, what we know from the studies is that the loading dose has no benefit and potential bleeding. From then on, we cannot say really anything else. Now, what the guidelines say, and maybe they're overextending, maybe they are. And the American guidelines still talks about 3 months of dual antiplatelet therapy, and this is what we follow at Mount Sinai Hospital.
Dr. Dangas, several years ago, I attended the webinar of MBCG AF, where you gave a lecture. In the discussion time, you mentioned very low dose of edoxaban would be okay in preventing reflex thrombosis. So especially edoxaban 50 milligram. In 2000, in latest ESC guideline, all patients who received surgical AVR and should receive the warfarin for first 3 months, after then single antipulse therapy. So how about adopting this strategy in post-TAVR patient? The first 3 months or 6 months, very low dose of NOAC, and then single antipulse therapy after that. So what do you think about my opinion, my suggestion?
I think this is a very practical opinion, and I do think that the edoxaban meets the dose reduction criteria quite often in TAVI population because of age and concomitant risk factors of renal failure. So one can say that a 30 milligram may be a more frequent dose for this indication. And it would be adequate to prevent the halt and the other aspects when you study it in a larger scale. Somehow it didn't pan out in your study, in the Korean study, in the ADAPT, but I think if in a larger scale, perhaps these differences would be statistically significant. Perhaps also has to do with the fact that the small halt in visualized in larger valves, and in the Asian population, the sizes of the valves are somewhat smaller, and perhaps this way you had less halt prevalence in the control arm than what we saw in the Galileo and apixaban populations. But regardless, I think that it's very reasonable to think that a short-term anticoagulation of a low level might be useful in our population. Because what we saw from Galileo and Atlantis is that the longer-term anticoagulation and the high doses and intermediate doses, it is associated with adverse events. But we can either limit the dose or limit the duration. And if you limit the duration, you also limit the side effects. And this particular early period, when everything gets endothelialized and perhaps clot is triggering more local inflammation or maybe hardening and pannus formation, if we abolish that, we may realize a longer-term favorable effect. So in general, I am enthusiastic about your approach, and I would like to see some studies about that.
Thank you. So, Dr. Meran, I have questions. I have long questions the result of ESA React 5 trial. In the ESA React 5 trial, prasugrel was superior to ticagrelor. So I still wonder this is true. So do you have your own interpretation of ESA React 5 trial?
I congratulate the investigators for doing the work, but I think that it was a complicated design with different issues. About 20% of the patients did not receive the assigned therapy. And I really don't think that you can show or there's any reason why you would imagine that there's a difference between prasugrel and ticagrelor. Or honestly, I really don't see how that's possible. That needs to be repeated for me to believe it. And I also believe that the fact that many of these patients who were supposed to be on ticagrelor actually didn't receive it. And so adherence to the study drug was an important aspect that was being missed in that trial.
Yeah, the superiority of prasugrel in the ESA-REACT 5 trial might be due to by chance or difference in strategy in non-ST elevation ACS patients. But at least we can say prasugrel is not inferior to ticagrelor. Before ESA-REACT 5 trial, ticagrelor showed some favorable results compared with the prasugrel in terms of mortality or bleeding issue. But after the ESA-REACT 5 trial, the prasugrel is at least as comparable to ticagrelor. If the efficacy is comparable between the two drugs, prasugrel is much convenient compared with the ticagrelor. Once daily regimen and the absence of some adverse effects such as dyspnea. So after ESA-REACT 5 trial, I prefer prasugrel to ticagrelor in real world in my practice.
There are additional supporting core data supporting for ESA-REACT 5 RCT, such as RENAMI, AMI registry, and UK STEMI registry. Sample size is several thousand, more than 10,000 patients. Of course, it is cohort. The results of prasugrel-based DAPT is better than TICA-based DAPT, even in UK or Europe. Thus, most of the people supporting TICA just raise a kind of fault in running implementation of ESA-REACT 5 RCT, but I respect the result of REACT 5 RCT because there are many supporting data favoring prasugrel.
Unluckily, our session time is over, and we are waiting for next session. So thank you for Dr. Meran and Dr. Tengas. We all enjoyed your lecture from you are the leaders in this field. So we are looking forward to seeing you later, especially offline in Seoul. And I'm going to close this session. Thank you for all speakers and discussion.
Thank you.
Good night.
Thank you.
Bye-bye.
Good night.
Thank you. Congratulations. Bye-bye.